Hello, I am Dr. Sajeev Nair. I'm a practicing orthopedic and spine surgeon in Bradenton, Florida for the past 20 years. I'll be talking today about low back pain, my back hurts, basic science and treatment. Low back pain is a leading cause of disability worldwide. In 2020, approximately 619 million people worldwide reported low back pain, and this number continued to rise. In the United States, annual cost of low back pain exceeds $100 billion, dollars, and it is primarily due to lost productivity and mounting medical expenses. Fundamentals of low back pain and its understanding is very important to diagnose, treat these problems. When we discuss low back pain, we have to think it as acute and chronic. Acute pain lasts from few days to 2 to 4 weeks, whereas chronic low back pain lasts more than 3 months, even after the acute or the primary injury subsides. 20% of acute low back pain become chronic. I will only be talking about acute low back pain in these slides, and I will focus mostly on the chronic back pain. Acute back pain, as we discussed, it is usually 2 to 4 weeks period. It lasts 2 to 4 weeks period, and usually it is due to sprain or strain caused by muscle or ligament injuries or disc injuries without much neurological involvement. And majority of these are treated conservatively. This I will discuss when I discuss about the treatment of low back pain. Another group will be acute injuries with disc herniation or disc injuries. Most of them do not have a neurological involvement and we treat conservatively. If disc injury presents with the neurological involvement, still we treat them conservatively for 6 weeks with various modalities. If that pain does not improve or continue to progress with neurological involvement or progressive neurological involvement, we then go to spinal decompression with microdiscectomy type of procedures. Another group of acute back pain is when they present with a severe neurological deficits and a cauda equina syndrome with a bowel bladder involvement. In that cases, we proceed with the surgical decompression with a discectomy. Now I will focus mostly on chronic back pain, which is what we usually see in the clinical practice. When we discuss low back pain, which is chronic low back pain, usually these are classified like mechanical axial low back pain versus radicular low back pain, which has a back pain component and nerve root compression involvement causing radicular symptoms. As shown in these slides, axial back pain is mostly in the lower back, which is in the paraspinal distribution or discogenic distribution, versus neuropathic pain, back pain associated with common terminology sciatica or radicular pain in the lower extremity, depending on the nerve root involvement. Neuropathic back pain is also result from underlying primary medical problems like diabetes, multiple sclerosis, stroke, etc., where we have a neuromotor involvement contributing to spinal instability issues or degenerative disc problems or muscle spinal unit instability contributing to the back pain. In order to understand, so we talked about acute back pain, which I briefly summarized before as treat conservatively and most of them resolve without much issues. Whereas chronic low back pain, to understand the chronic low back pain, you have to understand the functional stability of the spine. That is the concept to prevent chronic low back pain, which only means that muscles, as shown in this slide, the paraspinal muscle, superficial and deep, along with normal spinal column posture or the normal spinal column alignment, is essential to to that is it is essential to provide functional stability. Normally, the normal alignment of the spine with the paraspinal muscle support, along with neuromotor control, which is through the firing of the spinal unit through the anterior motor neurons and the spinal pathway, which is essential to that is to provide the functional stability of the spinal structures and the spinal column. If we can achieve this during our regular routine activities, we can have a dynamic functional stability of the spine maintained during the normal activities. This is essential to prevent injury to the spinal structures and to prevent low back pain. When we think about the spinal column, you have to know the normal alignment. This is a spinal column you will see here. If I am looking in a sagittal view from, this is the front and back, and this is called lordosis, then kyphosis, and then again the cervical lordosis. So this alignment of the spine is essential to prevent injury to the spinal column and surrounding structures. Then you have to know the normal loading process which happens during regular activities. Most of the spinal loading happens in the anterior column, which is the vertebral bodies constitute the anterior column. The posterior elements here, which is mostly for the range of motion and load sharing part of the normal activities. So if these are to maintain the intact nature of the anterior column and the posterior column, we need normal vertebral bodies and the disc in between. They are considered like shock absorbers, along with the posterior structures, which is this spinous process, transverse process, and then lamina, then coming to pedicles. So these structures, they are maintained through the ligaments, interspinous ligament, supraspinous ligament, interspinous ligament, ligamentum flava. This provides a stable structure in the back, which keeps each segment of the spine intact during regular range of motion activities. This helps the spine move as one column throughout the range of motion or rotation or bending or, or lifting weight, all regular activities. This intact nature of the spine helps to move the spine as one unit. When the spine used as one unit, the injury to the paraspinal structures, disc structures are very limited. Secondly, about the biomechanics, to keep here the concept is short lever arm. When we do activities, if you keep them short lever arm, that means you are lifting weight, you are holding close to the spine. or you are bending, you move the whole spine as one unit. So this causes less generation of force in the spine, thereby preventing the injury to the disc or the paraspinal structures. And this is essential, this understanding of the spinal column functional stability, maintenance of the functional stability of the spine during regular activities is essential to prevent injuries and chronic back pain. This is a biomechanics slide which shows how the instantaneous center of rotation going through the vertebral bodies just is at the junction of the posterior two-third and anterior one-third. And this is what is essential when we do flexion extension of the spine to keep the instantaneous center of rotation the same line, thereby the loading and force generation acting into the disc and other surrounding structures are limited and prevent injuries. Whenever you have a high lever arm moving forward or high force acting into the spine, this instantaneous center of rotation is lost, which causes excessive force to the disc or the mobile structures of the spine, like ligaments or disc, which causes injury. This is a mechanism to cause injury to the structures which contributes or which will lead to chronic back pain. In the second slide, you will see a bicycle. As we move forward in the bicycle chain revolves around around this wheel, which keeps in the same center of rotation. That is only possible because you are keeping the chain length same throughout the range of motion. Same concept is applicable in the spine, where you maintain the all the ligaments without buckling, at the same time keeping the instantaneous center of rotation same during regular activities to provide the functional stability. Then talk about the muscles. We have a paraspinal muscles. Superficial muscles are erector spinae. They are big muscle generators and they are big movers. So when picking up things from the floor, etc., when you move big, the anti-gravity force is generated in the superficial muscles. Whereas the deep muscles, which include multifidus, they are stabilizing structures in each spinal segment. They are essential for the spinal stability. When you have an injury, when you scar this deep multifidus muscles, then it is a cause of chronic back pain. In this slides, you see the MRI scan of the axial spine, which shows in a chronic back pain patients with a scarring of the multifidus muscles, the deep, there is deep paraspinal muscles. Now, if you understand the spinal anatomy and the functional stability of the spine, you have to also understand the neuromotor control, which is through the reflex arc. So this is the anterior horn cells in the spinal cord. We have afferent coming from the muscles. It goes into through the spinal cord into the brain. So this pathway is essential to keep firing the muscles, to keep the muscle tone during the normal activities. As long as muscle tone is maintained, muscle mass is maintained, muscle atrophy is prevented, we have a normal neuromotor control through the reflex arc, which will provide again towards the functional stability of the spine and preventing the injury and preventing the back pain. This again, that vicious cycle is explained when you lost the neuromotor control, whether nerve injuries, muscle injuries, or any of these scenarios which will cause overloading of the spine and instability of the spine, because the normal spinal unit stability is lost, which will produce an instability of that segment, which contribute to the back pain. So three things we discussed so far, which is normal alignment of the spine, like lordosis, kyphosis, again lordosis, cervical lordosis. This is important to prevent injuries and to get maximum mechanical advantage for regular activities, to decrease the force generation in the spine, along with the superficial and deep muscles of the spine and and then the neuromotor control. This act in together to provide functional stability. If you understand the functional stability and the anatomy of the spine, then you understand how we treat this. Acute back pain, I already discussed before, which is majority treat conservatively because no deep injuries are involved, only superficial sprain and strain, which is treated with the conservative treatment. Whereas chronic pain, majority of them, of the idea is to prevent the further injuries and rehabilitate with non-surgical treatment with multiple conservative treatment options, which I'll be discussing later. If there is a neuropathic pain where back pain is associated with nerve involvement, compression neuropathy, which usually are initially treated conservatively, after 6 weeks, if they continue to have pain, we will go to the surgical route if that will improve patient's symptoms like progressive back pain, progressive neurological deficits, or any uh, pain contributing to other secondary conditions. I will briefly discuss common scenarios we see in our clinical practice, which is degenerative disc disease. Even though acute and chronic back pain we discussed are approached through our understanding of the anatomy and biomechanics, degenerative disc, once the disc start degenerating, because disc is a mobile structure in the spine which always undergo loading, unloading, and contribute to the degenerative process. Disc degeneration, wear and tear happens mostly in the disc because of the mobile nature of the disc. The disc, you have to think like inner nucleus pulposus in the slide and outer annulus like a donut jelly and outside ring. When you violate the normal anatomy, you cause back pain. Various injuries of the discs are described like annular tears. Outer annulus is torn where the normal stabilizing structure of the disc is lost, or uh, or you have disc, various terminology, bulging disc, protruding disc. This only means that our annulus is not violated, and the posterior longitudinal ligament, this is the disc, and the posterior longitudinal ligament inside the spinal column is not violated. Once that is violated, or the annulus and the ligament is violated, and the disc enters inside the spinal canal, we call herniation or extrusion, which is herniation leading into the surrounding nerve structures, traversing or exiting nerve roots, and contribute to the radicular symptoms or the pressure symptoms. Sometimes discs get fragmented, which remains inside the spinal canal, inside the posterior longitudinal ligament, which contribute to the radicular symptoms. So whenever you have an injury, repeated multiple injuries to the disc structures with the repetitive stress, you get degeneration of the disc where the normal hydration of the disc is lost. As you've seen in the MRI scan, this become dark disc in a, as against a healthy nucleus pulposus and annulus pulposus, which is very bright signal. You get dark signal, which is indication this is a normal disc pattern, whether this is a degenerative disc disease pattern. When you develop degenerative disc disease, this causes back pain. When the degenerative disc disease progresses, it can herniate, which contribute to radicular symptoms with tingling, numbness, and radicular symptoms. Or degeneration continues to get worse and vertebral body's end plates get inflammatory reactions or inflammatory changes, and bone touching bone type of pattern develop, which produces abnormal loading into the end plate and produces osteophytes, which also contribute to the radicular symptoms or the back pain. So once a degenerative disc disease patients come to you with back pain, you do the clinical examination to make sure there is no neurological involvement. Once there is no neurological involvement and only back pain is the presenting complaints, we still have room to continue conservative treatment. However, if they continue to have neurological symptoms or persistent symptoms which is not responding to conservative measures, they will require further workup with imaging studies like CT scan, MRI scan, and regular radiographs. And the natural course of the degenerative disc disease process is mostly it remains like a plateau with up and down with small flare up coming down to normalcy, again flare up coming down to normalcy, up and down this pattern for a long time, or suddenly get worse when disc is mostly degenerated and it continuously causes constant back pain, contributing to disc herniation, or disc is not providing the stability and the vertebral body slip each other. We call slip disc or spondylolisthesis. Once the disc normal anatomy is gone and they are not providing stability or movement, normal motion to the spinal segment, this will lead to a deformity because spinal column is deformed. It causes deformity in the coronal plane, front back plane, or sagittal plane, side to side plane, cause scoliosis or lordosis or kyphosis type of deformity, or a combination of this deformity, which will cause abnormal loading and pain. So if you, this is what we commonly see in our clinical practice, degenerative disc disease as one of the most common cause of the chronic back pain. When we have a patients like that, initial treatment option is conservative. We do non-steroidal anti-inflammatory medicines, muscle relaxations, that muscle relaxants, and then cultivate a healthy exercise program with flexion, extension type of exercises, and then educating them to keep the functional stability of the spine, and other supplementary modalities like nerve stimulation, electric stimulation, acupuncture, various other modalities which will fire the neuromotor unit, thereby giving more functional stability. Steroids we uses, they have a role in decreasing the inflammation, uh, or if they have a neurological involvement and radicular symptoms, to decrease the inflammation around the nerve roots, we use epidural steroid injections. These one or combined, these modalities are used to provide maximum comfort to the patient, is the basis of conservative treatment. Once conservative treatment does not give a patient stability of the spine, pain relief of the spine, and their quality of life, if life is compromised, we have to think of surgical treatment. Again, this include posture, exercise program, aerobic stretching, yoga. These are all important to cultivate the healthy exercise pattern. Then other considerations like if patient is a smoker, very important to advise them to stop smoking, which will give a good healthy disc. Smoking always shown to cause disc degeneration and disc desiccation. Then again, overweight patients has to lose weight. These healthy habits will contribute to improvement in their back health. Then other newest treatment available is stem cell treatment, where we use umbilical mesenchymal stem cells directly injected into the injured disc. Some of the studies have shown good improvement up to 80% pain relief. However, more research is needed to recommend this treatment modality for disc injuries or the chronic back pain. However, the research is very promising. Stem cell injections, I have not done into directly injecting stem cells into the disc. I have not done because not it is not shown to produce good results, and insurance are not approved. However, I have used stem cells allograft for my surgical interbody fusion, which I'll be discussing shortly, for chronic back pain, disc disease, deformities, which is 100% provided lumbar interbody fusion and excellent patient pain relief and outcomes. Stem cell allograft is standard approach in my clinical practice for lumbar interbody, which is after removing the disc in between the vertebral bodies, we put interbody implant filled with the stem cell allograft implant to achieve interbody fusion. This works very well in my practice, and I have thousands of patients I have performed with excellent outcome. Now we come to, once we failed all the conservative options, we are coming down to surgical treatment options. Surgical treatment options, why? Because of this will help to remove the injured disc and which will regain the stability of the spine. When will we do it? When conservative treatment fails and patient continue to have neurological deficits. Why not? I do minimally invasive surgeries. I do not do open surgeries. It is because of the fact that it will prevent the tissue destruction and scarring, whereas minimally invasive surgical options will enhance quick return back to work or return or decreased amount of pain with good outcome because of the less disruption of the tissues. I will briefly measure the inner body, which is removing the disc and achieving the fusion for chronic back pain. Traditional units, traditionally we come through the front, remove the disc and put inner bodies, or through the back, directly through the back we call posterior lumbar inner bodies, or through the transforaminal. But the approach I use is very minimally extreme lateral interbody, where this is the patient's side, where small incisions are produced and approach this directly. What I have done in the past 20 years is remove the disc through the side with a small incision and introduce a 3D implant filled with stem cells, which produces fusion of that segment without destabilizing any structures like ligamental structures or posterior elements of the spine are not disturbed, since we are approaching directly through the side into the disc. I will show my experience with this direct lateral, extreme lateral interbody fusion. Patients are positioned in the side position and they are monitored through the nerve monitoring. And nerve monitoring shows all the nerves are monitored through the nerve potentials, which is EMG, or SSEP, which is being recorded and monitored through and then monitored by a neurophysiologist. The advantage of doing this disc type of surgeries are very less blood loss, directly approaching the disc without disrupting the structures, thereby quick return and less morbidity. I will show some case studies where degenerative disc disease, how this particular side approach of removing the disc and diffusing them through this device, through this interbody implants, has helped them. This is a patients where you see two vertebral bodies are slipped out, disc is coming and compressing the spinal cord. This is an axial cut. It shows severe stenosis. And what we have done, I come through this side and put a disc implant, which reduce the slip and gain the stability. And this will fuse these two segments and provide the stability of the spine. In this case, after we have done, we come through the back and stabilize the segments through the pedicle screws as well. This is another patient with severe disc degeneration contributing to scoliosis deformity, where we approached through this side and put multiple interdisc implant and corrected the scoliosis to a great extent, thereby decreasing the pain. Another patient again with severe degenerative disc disease, disc is degenerated and deformed. These are nothing conservatively we can help these patients, patient groups. We have to do surgery to help them, where again the approach is through the side, remove the disc implant through the side and correcting the scoliosis to a great extent, and indirectly when we put the implants in here, this will indirectly open the spinal canal, and it decreases the pressure on the nerve roots and relieving the nerve pain and back pain. The incisions are small 1-inch incision through the side, where the disc is removed and implants are placed filled with stem cells. Another case where disc is degenerated, osteophytes develop and a deformity progressed, again came through the side, disc is removed and interbody implants are placed with the stem cells, which has corrected the deformity and indirectly decompressed the spinal stenosis. Another case where severe deformity, where initially come through the side and put disc implants, and through the back we have produced instrumentation to keep the normal spinal curvature. These are how the incision looks. Small incision through the sides to do the disc, removing the disc and implant. Through the back, multiple incisions, which is to decompress the spinal canal if they have severe stenosis, and put screws if scoliosis is the underlying deformity to keep the spinal alignment. I will show a patient slide at this time where this procedure is performed. This patient has severe spinal stenosis. This patient has radicular symptoms. She was placed in the side position in the operating room. Body is connected to the nerve monitors, which is recording the nerve potential. This is the incision, which is about 1 inch in the side of the body where the patient is placed. The finger dissection going through the dorsal lumbar fascia into the extraperitoneal space. So finger dissection through the extraperitoneal space into the disc space. I'm in the extraperitoneal space. In the disc space, a black dilator is placed in the disc space, and I'm going to check that with the fluoroscopic imaging. Come on, David. So We locate the disc space with the help of the fluoroscopy, which you can see in the screen. Multiple diameters. Then I'm in 12 millimeters, and then I'm inserting the retractor. So once the dilator is placed, multiple dilators followed with a retractor is placed, which is secured in the table. Then through that hole, we remove the disc once it is placed correctly. The disc is removed and a trial size was obtained and an interbody disc implant was then placed, which is secured with a small lateral plate. We have a incisions which is about 1 inch in long, which is 1 inch in length. We finished the operation in 20 minutes. Each level, even less than that, even with high risk for nerve injury, we have the nerve monitoring, and the neurophysiologist reported that there is no abnormalities with the nerve potentials, which is recorded. Thank you. And these incisions are deeply closed and superficially. So this is a crossed with the dermabond dressing, which will automatically, we don't have to remove anything. This will dissolve by itself and disappear. Thank you. And you had a surgery yesterday. Today, day number 1, morning. So how did you do? Did you walk, and what is your experience?
The first time I walked, it was a little rough. I had a little bit of pain, but it didn't radiate down my leg. Every time I walk, it gets better. I've been offered Motrin, Percocet, and Tylenol, and I prefer to take it easy on the medication. I am on Tylenol only.
Oh, excellent. Great. So can you show us how you are walking, Linda?
Sure.
So this patient had
Look at that. So she doesn't even need any support, and you're
procedure to the
walking
side.
without
Next
any
day,
support,
she's walking
and you don't feel any weakness
without
in the
any
legs, nothing,
supporting
right?
device.
Okay, perfect.
And she's ready to go home. And she's only taking Tylenol.
Excellent.
So in conclusion, low back pain is a debilitating disease. Prevention strategies are based on the understanding of the basic science of maintaining functional stability of the spine while engaging the routine activities. Most of the acute and chronic axial nociceptive pain is treated conservatively. Neuropathic back pain require workup and a surgical treatment with a spinal decompression to address the spinal stenosis and the stability. Spinal stenosis and provide stability of the spine. Minimally invasive surgical options to treat severe degenerative disc disease with severe degenerative disc disease resulted in excellent surgical outcome and patient satisfaction. Thank you very much for listening to my low back pain CME talk.